Good morning, good afternoon, everyone, and welcome to Top Voice Tuesday. It is April 29th. Incredible to believe we're already at the end of April here in 2025. Super excited to have with me today Ruth Krystopolski, who is another amazing top voice who I'm excited to give you a chance to get to know here in a second. Um, Per usual, some easy introductions. This show's on every Tuesday. If you've missed past episodes, they're all hosted on my YouTube channel, Michael J. Lopez 9. Would love for you to check that out and subscribe to that. And every Friday, we turn this conversation into a set of insights that go out in a newsletter that can be found on my website, and I'll put those links into the chat when we're done, and into the show note captions. So. Thank you again for being here and being part of this show. Ruth, I want to give you a chance to introduce yourself. Please share your background with everyone. We're going to talk about healthcare equity today, and we're going to talk about if it's at a crossroads. But Ruth, please, over to you. Welcome to Top Voice Tuesday.
Thank you, Michael, and thanks for having me. I'm so excited to be here. I'm Ruth Krystopolski. I'm president of Eye and Health Solutions at Providence Health, and I've had the blessed opportunity to work in healthcare now for 35 years this year. I've worked where I say is the intersection of how healthcare is paid for and how it's delivered, and have really been again blessed to work in all parts of our country, and I've even done some international work. Um, thank you, Michael, and really excited to have this conversation today.
Yeah, no, I appreciate it. We've been on talking about some different topics lately, and I'm really excited to talk about this one. When we first met, it was one of the first things you mentioned in your healthcare career, and we're certainly at an interesting point socially and politically and economically, and that is influencing heavily where we go in the healthcare industry and this concept of healthcare equity. Before we get into it, Ruth, tell us about your Top Voice journey. How did you get to the top of the Top Voice mountain?
Well, to the top. And I have a great background picture there. That's Mount
Perfect
Rainier.
one for this question. Yeah.
Yeah, outside my window. I started using LinkedIn in about 2014, 2015. And so I kind of was an early adopter of LinkedIn, really to connect with the community around me, particularly the business community and other individuals in the healthcare sector. Early on it was a little clunky, and the tools and the ways to engage were less, but kind of began with a consistent posting of information on things that were going on in the healthcare environment. Over time, I would give myself a challenge to get to 1,000 followers, and then get to 2,000 followers, and so I think that kind of constant approach of both engaging in posts that other people were putting out there, developing my own content, as well as like having goals on, how many people I was connected to and how many people were following me, really kind of was the foundation for getting to a top voice. I think the other thing that I learned, and I continue to learn and kind of iterate around, is a mixture of sharing both personal and professional reflections, is kind of the secret winning formula in LinkedIn. I'm always really surprised when my reflections about my own personal life and challenges and some of those things do significantly better from an engagement standpoint than the things that I write about that are like technically oriented around healthcare. And so I've learned to kind of balance both over the years, and try to keep engaging content out there for the audience. And so that's kind of how I've gotten to where I'm at. And I can tell you, I don't know that I was intentional about it at the very beginning, but I've been much more intentional about it over the last, 5 years or so. As LinkedIn has become a good channel to connect and engage with others.
Yeah. We talked about this, and I love that story about this idea of setting these incremental goals, right? Just having a marker, 1,000 followers, 2,000, not because those numbers empirically mean anything in and of themselves, but it's a way to sort of gauge, am I taking the right steps? Am I taking all the right actions? And we talk a lot about that. I was talking about that in my book about, it's the process of setting goals and putting effort into pursuing goals that actually matters more than the goal itself. You'll
Right.
find yourself really, really far down the journey of change if you're able to just sort of set those waypoints. And we talked about your personal reflections that you share and how surprised you were. I just did a post last week um, about sharing a personal reflection about the idea of losing and what that does in terms of our brain, right? We value loss more than we value gain. And so I shared a little reflection on that. I think people really enjoy seeing people maybe in our circumstance be vulnerable, right? To know that they're not alone, that they're struggling with the same things. So thank you for sharing all of that. One other question, and I know that you've shared, particularly your thoughts and experiences as a woman in this industry and as a woman executive in this industry. Share a little bit about what that's been like for you on your Top Voice journey and sharing those insights.
Yeah, and again, I think quite an evolution over the 35 years. My very first job as a leader was in, the early 1990s. And in many cases, because my background is finance and IT, I was often the only female in the room, and in many cases the only female leader in the room. And so it often was a lonely place, Michael. And we were all asked to do and behave in certain ways. 30 years ago, as women leaders, that I'm hoping, and I see it in the places I'm in now, where women are not forced to behave or act in a certain way, right, in order to get ahead. And so, I try to engage regularly with women and young women who are looking to leadership roles. I do a lot of both formal and informal mentoring and sponsoring of young people, and it's again been a blessing to learn from my own past and then kind of use that to share with this next generation of leaders. I even, I'm currently teaching at the graduate level in the Master's Health Informatics and Master's Health Administration program, and just enjoying every minute, right, being with learners and helping them as they're thinking about what their next role is. So it's been a great journey.
Yeah, well, that's wonderful, and thank you for your leading by example and being such a guide for other women who are trying to navigate their own careers, whether it's in the healthcare industry or otherwise. And it's such a gift for you to be giving back. Um, well, let's jump into your experience and this topic. For those of you dialing in from around the world, we've got a watcher from the Philippines, Annalise. She's one of our favorite tuning in. If you've got a question for Ruth along the way, please do ask. So, healthcare equity. This phrase may not be widely understood by a lot of people. So let's start by just defining it. What is healthcare equity?
Yeah. And so healthcare equity refers to the fair and just opportunity for all people to achieve their own optimal health, regardless of their social, economic, or geographic circumstance, right? And when we think of health equity, we usually think about it through the lens of four different kind of areas. First is equality of opportunity, right? So does everyone have access to the resources and services necessary to maintain and, in some cases, improve their health? The second is really addressing what we call social determinants of health. So, recognizing factors like poverty, discrimination, and lack of access to both education and services that would significantly impact health outcomes. The third is the focus of eliminating those disparities. So, reducing the differences in outcomes across the different groups. And the final area really is promoting social justice. So, ensuring that people have the power to actually advocate for themselves in achieving optimal health. And so, as I think about kind of health equity, I think about it from the standpoint of improvement science. So, how do we identify where healthcare outcomes are different for subsets of the population and then provide interventions in order to um, standardize those outcomes across the different groups? The one thing that I do want to just make sure that people understand is DEI initiatives, so diversity, equity, and inclusion initiatives, are not the same as health equity. And I think in some cases we're conflating those two things as we talk about it. And as we're thinking about kind of opportunities for employment and ensuring that our workforce and our teams reflect the communities that we work on and giving everyone the opportunity to move forward, those are DEI initiatives. When we're thinking about health equity, it's really what factors are influencing the actual health outcomes of a population, be that around race, ethnicity, education, geography, that somehow impact, right, those outcomes negatively. So I do want to kind of put those out there because I think sometimes we're conflating the two and they really are two different things.
I'm glad that you pointed that out because people were probably thinking about the parallels in maybe the definition, but I think you've hit on something really important. This is an incredibly complex topic that does have a relationship to the idea of, equal access, which I think is what you've described in these four dimensions. Has this definition, I want to come back to that, but I want to talk about the definition that you just gave in these four factors. Has that always been the traditionally understood definition of these things, or is there something that's evolved over time?
Yeah, I mean, I think research going back, 30, 40 years really brought out the fact that there were different outcomes in different patient populations with regards to control of diabetes. I mean, you could pick any kind of condition. I don't know that our complete understanding of kind of what the factors that were influencing were until probably about 20 or 25 years ago. But we know in healthcare, only about 20% of outcomes is tied to the actual delivery of healthcare services. The other 80% is impacted by things like education, the environment that we live in, right, and our access to services. And so, we often say that a person is influenced more by their zip code than their genetic code in their health outcomes. And I think that's a learning that we've had over the last few decades. The data necessary really to start to look, Michael, at these at these differences is becoming more and more readily available, and I think that'll allow us to continue to improve more quickly as we use data really to understand the differences and then which interventions are actually having an impact in improving, right, the outcomes for different populations.
Wow, you hadn't mentioned that phrase to me, which I think is incredibly powerful, that your healthcare outcomes are more of a determinant of your zip code than your genetic code. That is an incredibly powerful statement, and I think reality about this idea that we have that access is such a big component. Just as an aside, I was listening to one of my favorite podcasts is the Revisionist History podcast by Malcolm Gladwell, and in season 12, I don't know if you ever listened to it. It's really good. They talked about the in the south of Chicago that putting a trauma center. Obviously Chicago is one of the most sort of violent crime dangerous cities, and the data goes back a long time. That the access to trauma center within a certain mile radius has some sort of huge impact on health outcomes because of the ability to get somebody to care quickly. I want to dive into this question a little bit more and maybe the data on that. Are there other when you talk about health outcomes, is it just kind of corrective care, trauma care? Is it preventative care? Is it the whole kind of dimension of, healthcare outcomes? Say more about what that means, because I'm sure most people didn't understand that
Yeah.
was a reality.
Well, again, I think it's multifaceted and it includes things like access to acute care services, like when you're having a stroke, right? Like there are certain interventions when you're having a stroke that if you have within a certain time frame, you have a one better chance of living and better chance of living, right? Your
Yeah.
highest life possible. We need to ensure that access to those things are readily available. But if you think on the prevention side, and I'm gonna use vaccines. I know some people don't want to talk about vaccines, but I'm gonna talk about
Let's
them.
just talk
Uh,
about loaded
right, we're
topics.
gonna
That's
use
what this
that.
conversation's
Yeah,
for.
we're going to use that as an example, right? We built infrastructure across the country to deliver vaccines in a number of ways because not in every community, right, is there access to a primary care provider or pharmacy that can give vaccines, right? So we do them in the schools. There are mobile opportunities, right? We're going into communities. Some parishes have parish nurses doing vaccines. And so I think this idea of how do you build like a quilt, right? From an access
Mm.
standpoint, not just for acute care services like trauma and perhaps stroke care, but for preventive services is really important. The one thing we learned from the pandemic that was really, really helpful in healthcare is healthcare access can be defined in a number of ways, right? It could be a physical location, but it also could be perhaps a video connection, right? And are there ways to use technology to engage individuals that are in communities where there's lack of transportation? Perhaps the timing of the day doesn't work for somebody to right get on two buses to go to a doctor's appointment, right, and miss a full day of work. So really starting to think more creatively about how we define access and then how do we define it within the rhythm of someone's life that makes it easy for them to engage and access in optimal health. I think are things that we're going to get better at and we're learning about right every day.
Yeah. This is just it's such to your point, right? Every circumstance for every individual is so unique, and it's such a function of their own experience. And yet we're trying to create a set of avenues and pathways for access to people. Um, I want to talk a little bit about why this matters, and it might be obvious to everyone, but I want to maybe just ask first. So we're obviously going through a very turbulent time in terms of policy in the United States on a number of fronts, right? And people have strong feelings, on multiple sides around that. Talk to us about how the shifting policy landscape is affecting healthcare in general, but this idea of healthcare equity. What's changing around you that you're contending with?
Well, again, like if I take a 30,000-foot view, I always ask the question, should everybody have the opportunity to live their healthiest life possible, right? Regardless of their circumstance. And I think most of us would say, yes, that's really important. I do think in healthcare, like a lot of other industries, people move to where the funding or requirements are, right? So we're either incentivized to behave in a certain way or we're penalized if we don't. And the thing that I'm most concerned about in healthcare is many of the, I'm going to call them requirements that have been put in place over the last decade plus that are going to help us advance, right? Addressing equity, right? At an individual circumstance level, right? We need to know about a person in order to intervene and help them live their healthiest life possible, right? Or set up the environment so they can be as healthy as possible. Many of the data elements necessary to do that were being put in place from a requirement standpoint, from a reporting standpoint, right? And so you're going to be penalized if you don't collect the real data, real D data. So race, ethnicity, right, language, disability data around a particular group of people, right? And so everybody was building systems and the ability to collect that data, which then allows us to look at outcomes, right, within those subpopulations and understand, right, where there might be some inequity, right, there. Many of the requirements are being rolled back, right? And what I worry about is the momentum that we have and the recognition that we have that there is an opportunity, again, from an improvement science standpoint. If we're trying to improve the health of all, understanding how improving the health of the subpopulations can actually move us forward faster, right? So if we're focused on interventions on those that have the lowest scores, right, we tend to bring up the overall group together. And so I worry about that somehow this idea of, equal outcomes, equitable outcomes, for individuals from a health standpoint kind of gets lost in some of the noise. And we're removing some of the requirements and incentives that were put in place to collect and use this data. And it's healthcare moves very slowly, Michael, right? We talk about change, and change in healthcare is really hard.
I'm
And so
aware.
I worry that, right, like, do we lose a decade as we pull this back, right? And then we have to catch up again. So I'm hoping that the organizations that are committed to this work continue to do it, whether it's a requirement or not, so that we can continue to improve healthcare for all.
Yeah, you've said something really important in the midst of that I want to touch on. But to acknowledge that last point, I think so much of this policy conversation, we're seeing it in what I would call other industries, right? We're seeing a response on behalf of initiatives that maybe these companies feel like they're still committed to, despite some of the policy shifts coming out of Washington. And so I think there is still a lot of individual choice there. But you've said something that's really important about what I'd call the marginal costs of taking someone who has very low health outcomes versus someone who has high outcomes, right? A dollar spent for someone at the lower end of that scale kind of gets you more, but we don't always think about it in the investment's higher. Can you talk to us about that reality, right? This idea that where we spend our money in the healthcare system and why that matters, and maybe how people might be thinking with a bit of judgment around some of that, because I think that's part of the challenge, right? You go into an ER and you see a lot of people that don't have health insurance and they show up there because that's their only option, right? So how do we talk about that in a way that's not so loaded, but acknowledge where we are and how to go forward?
Yeah, and again, I think, just like, I mean, if you use an example from education, right? A child with, and I'm going to use my own daughter. She had some reading challenges from, dyslexia, right? She needed some special attention and help early on, right, in order to, work through those challenges and become a really good reader. I think assuming that an individual that, right, lives in, in an area where there's no access to a pharmacy, right, that may not have the capacity and ability to understand how to use their medication, and and why they're using it, and comparing them to me, who's, I've been in the healthcare system for a long time. A dollar spent on me is definitely not going to give you the same outcome as a dollar spent on an individual who might have access and kind of literacy challenges. And I think we need to understand that we all start at different places. And so equity means getting everybody to the same place, but not necessarily with the same inputs, right? There are some individuals who need more help than others, and identifying who those are and addressing what some of those needs are, I think, are really important.
Yeah, what a great concept. I think that on a human level to understand, and there's a comment in the chat that I want to read out so everyone can see it, is that the goal of equity is to get everyone to the same finish line, acknowledging that we might be at a different starting point. And I think so much of that around education, around healthcare, around skill development, around professional growth is the idea of how do we get people to the same, help them help themselves. This is also a personal responsibility thing. Nobody's suggesting that we don't play a role in our own outcomes, acknowledging that everyone starts at a different place. And for me in the change world, that's absolutely, I say this all the time, right? No two brains on planet Earth will ever be the same. And so we can't just use a paintbrush and pretend that if we brush everyone with the same color paint, they're all going to get there at the same pace. So thank you for acknowledging that. And I think it's just the difference between a policy conversation and a human conversation, right? And the goal of policy is to help humans, and we recognize that that's an imperfect science as well. I want to read a comment from the chat here about from Maria Hernandez, that one of her firms is one of the AHA's equity transformation partners, and we have not, in capital letters, deleted any of the health equity standards from our inclusion scoreboard or scorecard for population health. And so they're certainly committed to staying the course. Can you help us understand what these healthcare equity standards are? We talked about this health equity index before. And let's maybe come back to that point with our last few minutes about what's the challenge going forward now that we've got data, we've got some changes. Where do we focus? Where do companies focus? What are the challenges they're facing going forward?
Sure. So one of the latest, greatest kind of requirements that I was like so excited to see both in the Joint Commission, as well as some of the other accrediting bodies, was the necessity of doing a social determinants of health screening on individuals that were either hospitalized or engaged in some way in the healthcare system. So really looking at things like their living situation, right? Are they housed or not, right? Do they have transportation issues, right? Do they have access to healthy food, or have, some food concerns? And then using that data and information to actually provide interventions, right, that might begin to address those challenges. So,
Yeah.
as an example, in the state of Oregon, there are programs currently underway that actually fund things like climate devices, so air conditioners, refrigerators, and other things that help individuals that have specific health conditions to better control their environment. They're also implementing kind of a food as medicine program, so providing things like medically tailored meals or pantry stocking for families that might have food insecurity, right? As we begin to address the broader issues that impact individuals, right, on a day in, day out basis, we give them a better opportunity to stay healthy and to optimize their health status. And as Maria, clearly said, we know this works. There's data to show that these interventions, collecting the information and then acting on it, actually improve things like the number of times people are readmitted to the hospital, right? Their ability to maintain kind of good outcomes from a diabetes standpoint. And so I just hope, Michael, that there are more organizations like the one I work for at Providence, and the work that Maria's team are doing, that are going to continue to invest and focus in these areas, because we do have health equity issues in this country. And our ability to improve the health for everyone starts with our ability to improve the health and the individuals that have the greatest disparity in outcomes.
Yeah, what a wonderful message, Ruth. And I think it parallels what we understand about the human experience, right? Which is this idea that that change and improvement in outcomes is a consistent personal experience based on repetition and education and struggle and adjustments, right? And so it's absolutely a difficult thing to understand. How do we treat everyone where they are and give them the tools they can to really take ownership of these outcomes? I saw a post the other day on LinkedIn about somebody who was kind of um, giving a little bit back to the longevity community. And they were saying, it's not that I don't have any problem with people who want to live a long time, but why are we spending so much time there and not at the bottom of the scale where we have, so much opportunity to change the curve for people who are really in need. And so I just want to thank you for doing the work that you do, and for the folks on the line. So many people really, really doing important purpose-driven work, helping people's lives. Before we wrap up, Ruth, I just would love, just what are the three things you really want people to take away from this conversation about the future of healthcare equity?
Sure. So, first and foremost, that health equity really is grounded in continuous improvement process, right? And that we need to continually to work to improve outcomes for all people, right, in our country and quite frankly in the world. So that's the first thing. I think encouraging people to commit to continuing to do the work, even if it falls out of favor, right, from a political standpoint, if we have to call it something different or right? Like relabel it. I think that's what we need to do, but we need to continue to focus. And I think the third thing really is, so goes health of our community, goes the economic status, right? So there's a direct also correlation between kind of economic right growth and a positive trajectory with healthier communities. And so it's all intertwined together. And we need to know that as we lift right individuals up from a health standpoint, we're also giving them a chance to lift themselves up from an economic standpoint. So it's a great investment all around.
I love that. And I think the one thing I'd add to your summary is the challenge with these kinds of outcomes is that the time horizon to realize the return is in some cases years or decades. And we struggle as people. We know that the farther away the benefit, the harder it is for us to make the changes that happen and that we need to make happen in our lives now. And so that's what I think makes this even more complex than you've already, so beautifully described, is that, the money you spend today isn't going to show up in terms of those outcomes for many years. And yet we have to stay the course. And, again, I just say that so much of our own individual journeys in life is, the delayed gratification that we have to withstand the struggle is just a big essential component of the human experience.
Right.
So Ruth, we're going to give you your last question, which is always a fun one, a little bit of a different topic from what we've talked about today. And I just want to thank you again. This has really been such an incredible, we could be here for hours talking about how complex this is. And Ruth, so this is the question left for you. What's one conspiracy theory that you believe in, but you've been afraid to admit out loud?
Oh, that's a really good one. That UFOs exist.
I don't even know
that there really were kind of UFOs that landed kind of in New Mexico, and the government covered it up so that we don't know.
I actually think a lot of people believe that now. So there you go. Well, you've said it now on the airwaves, so it'll be part of this record for forever. And hopefully we get to find out if that's true or not. Thank you, Ruth, again for your time. Is there anything you'd like to offer up to folks who are listening or tuning in?
Yes. One, please connect with me on LinkedIn. I'd love to get to know all of you. And then two, I write a monthly newsletter called Simplifying Healthcare. And I'd love for you to subscribe to the newsletter. I try to break down really complex issues in an easy way, both for healthcare and in some cases for my own personal life. And so please subscribe.
Yeah. And if this conversation hasn't demonstrated to everyone listening, Ruth is the expert. She understands this landscape better than anyone. And so what a resource if you're in this community. And so please do subscribe to that. Thank you all for tuning in. Again, if you want to go back and look at other episodes, Michael J. Lopez 9 on YouTube. I do have my own newsletter. And if you get a chance, we talked about a lot of change topics today. You'll see the book in the background. Please go check that out. It really covers a landscape of these issues that we covered today. Ruth, thank you again. Thanks everyone for joining in for Top Voice Tuesday, and we'll see you next week. Have a wonderful week.